Thank you, Dr. Abrama, and it's nice to be here again. For me, it didn't travel very far. It's only about 2 hours away drive. So I'm going to start with a case. This has happened just a few days ago. It's a routine day in the clinic on a Wednesday. I got a call from two of my colleagues. 69 years old gentleman with history of stroke and right arm weakness about a year ago. Now present again with slurred speech, now right leg weakness, and MRI showed left frontal infarct. And this is a patient, the COPD on HOMO2 has a relatively high carotid lesion, not that you can get to, but a big carotid mass. Morbid obese, very short neck, as you can see on the CT scan. Now this is a patient that my colleagues decide this is really high CA risk, which I agree. And again, very short neck, less than 5 centimeter carotid from the clavicle to the carotid lesion. And anterior cervical fusion, and with a large anterior neck scar, limited neck mobility is high risk TCAR candidate. So this is happened on Wednesday, and then I was told, well, maybe you can do a transfemoral stent. This is a symptomatic patient. This is probably the only best option for him, and we'll book for you for Friday. So here's the angiogram. As you can see, tight carotid lesion right at the origin of the carotid, internal carotid artery. And then I went ahead had a carotid stent. Patient uneventfully, luckily patient recovered, no issues. And this is silhouette of the patients. I just want to point out, as you can see how big the patient is. Most of his weight seems in the upper in the neck and chest. So at minimum, transfemoral stents provide an alternative for patients with symptomatic carotid lesions, not TCAR candidate, not CEA candidate. Now with an option, transfemoral stents prompt multiple randomized control trials. And this is a CREST-1 trial, compares CEA versus CAS, both in asymptomatic patients and symptomatic patients. As you can see, the risk of stroke and death, really the difference really at laser the para procedure. Long-term carotid stent has a durable outcome. Here's another trial, compares carotid CAS versus CEA. Again, the difference really lays in a para procedure with good long-term durable outcome for carotid stenting. Now, SPACE 2 trial is an unfinished trial. Some may say this may be a missed opportunity. Others may say this shows the challenges in carotid space. And their trial was couldn't finish in recruitment, but required over 3,000 patients to see a difference in clinical outcome. And really that shows that the outcome probably very similar. That requires so many patients to see a difference. And that's actually raised awareness of a procedure-related microembolization. And transfemoral stenting has higher procedure-related microembolization, even subclinical, but long-term outcome of cognitive outcome is unsure. And so maybe this could be an alternative outcome for procedure. It also drives transfemoral stenting from there, really drive research on cognitive impact. At least my research for over the last 10 years, where I've showed multiple over and over, microembolization does have a cognitive effect. And this is just some of the papers we published over the last 10 years. And we also look at the volume of microembolization. Transfemoral stenting and microembolization prompt more investment from industry and some innovators on better embolic protection device. TCAR is really a better embolic protection procedure where there's a reverse flow so that you reduce per-procedure embolic risk. And outcome, as Dr. Kasaraja showed, is fairly good, comparable to CEA in most of the cases. And with that, there's really rapid adoption of TCAR has significantly increased over the last few years, even more now after the CMS approval. And transfemoral stenting has been similar, have been steady over the years. Here's a study shows real-time VQI data with midterm outcome. Again, the difference really lies in the peri-procedure, and the long-term is very comparable for stenting versus CEA. Now that's led to the CMS approval for transfemoral stenting for asymptomatic patients and symptomatic patients. So we all know that microembolization does not really happen just at the procedure, just at happens over 48 hours later. This is an old paper by Zhou and al. It shows that at 1 hour, only 9% has microembolization, has DWI lesions. But by 48 hours, that's 78%. What that means is that embolization continues after the procedure. So that leads to more innovation. Now there's more whole set of meshed stents to prevent that continuous microembolization. And here's a study compares the regular non-mesh stent versus mesh stent. As you can see, there's a significantly higher microembolization over time for the without mesh, and the mesh stent seems significantly improved in microembolic rate. So how does the transfemoral stent affect carotid space? At a minimum, transfemoral carotid stenting provides an alternative for high-risk patients. It has prompted multiple randomized control trials to evaluate the long-term clinical outcome of carotid intervention. It had raised awareness of procedure-related microembolizations and drives future research on cognitive impact. Transfemoral stenting have driven technical innovation from better embolic protection to more newer design stents. And it provided opportunity for transdisciplinary collaboration. The picture this was only a couple of months ago. One of my cardiology friends called me, basically says, this patient had transfemoral stenting, now has severe stenosis and stent fracture, as you see here, asked me if I could take it out. So I took it out and reconstruct the carotid artery. So that collaboration in the right setting is really benefit for future patient care. Thank you very much.